Morning, everyone. Thank you so much for coming our first SCTS Cardiothoracic Virtual University Forum. Today's topic is going to be cardiac surgery and new innovation. We have four excellent speakers. The first speaker is Mr. Sean Shanmugam. He is going to talk about mitral valve surgery in the 21st century. The second one is going to be atrial ablation surgery by Chris Tecker. Third is Mr. Ganesh Shoban talking about endoscopic vein harvesting and radial artery harvesting. And the fourth speaker is going to be a role of mechanical circulatory support, Vipin Mehta. Let me introduce our first speaker, Mr. Sean Shanmugam. He works as a mitral surgeon from Liverpool Heart and Chest Hospital, interested in minimally invasive robotic mitral surgery. Thank you so much, Sean. You can.
The red button so you can leave the stage. Thank you.
Good morning, everyone. I hope you can all hear what I'm hopefully trying to explain. Can you hear my voice? I have no way of confirming it, and I hope you can hear me, and do apologize for my voice, and I hope these slides will work too.
We can hear you, Sean. We can hear you very well.
And it's mitral valve surgery in the 21st century. I'll touch upon mainly on the minimally invasive surgery, i.e. right thoracotomy, robotic surgery, and if time permits, a bit of percutaneous on transapical mitral intervention. Next slide, please. Next slide, please. Thank you. And traditionally, sternotomy is the standard procedure, and still perform this for mitral valve intervention, and it just gives good results. As you could see, this is what it looks like. And would we prefer this? Next slide, please. Or this, where it's obviously less messy, and it gave good results at the end of the day. Next slide, please. And the final outcome is like this, where the patients recover early, get home early, and I won't be surprised, given the choice, I think patients, or yourself and myself and my family, I would choose the same as minimally invasive, I guess. Next slide, please. Thank you. So there are potential benefits for minimally invasive surgery, i.e. reduced trauma and pain, less blood loss, lower risk of infection, shorter time in the hospital, faster recovery, smaller noticeable scars. The patient can go home early and drive early, get to their work better, and they do not have any restrictions in doing exercise and their exercise tolerance. Next slide, please. Is there an evidence for this? Yes, we do have a lot of them. I will touch upon a couple of them in the next slides. This is the paper from Cleveland Clinic about 2-3 years ago, which clearly shows the minimal invasive thoracotomy and robotic mitral valve repair, with or without other complex procedures added to it, are safe, effective, and durable for complete correction of mitral valve prolapse, regardless of its complexity. Further, minimally invasive techniques offer reduced blood loss, lower risk of infection, shorter hospital stay, quicker return to normal activities, and superior cosmetic results. Next slide, please. And again, it's another paper. It's not about 2-3 years ago, where they looked at propensity matched about 2,300 patients in non-emergent isolated mitral valve operations, comparing robotic, minimally invasive, and conventional surgery. They concluded, despite longer procedural times, robotic and mini patients have similar complication rates, with higher repair rates and shorter length of stay metrics compared with the conventional surgery. Next slide, please. So what about the cost? I will try and explain the next two slides. There are some evidence to it. The next one, please. This is the paper from 2016, which concluded, compared to conventional sternotomy, mini mitral valve repair or replacement in the real world demonstrates no difference in major morbidity, but was associated with shorter length of stay and fewer transfusion rates. Next one, please. And another one not long ago as well, where the minimally invasive mitral valve surgery is associated with excellent resource utilization in the real world. And it continues to demonstrate excellent results with a favorable resource utilization profile again. Next slide, please. And you don't have to go too far. Let's look at our UK outcome. Next slide, please. There's a beautiful meta-analysis of, propensity matched analysis of the minimally invasive approach versus sternotomy was carried out, which concluded minimally invasive surgery is associated with excellent short-term outcomes and comparable mid-term outcomes for patients undergoing mitral valve surgery. A minimally invasive approach should be considered for all patients who require mitral valve intervention and should be the standard against which transcatheter mitral techniques are compared. They furthermore go on to say that minimally invasive program should be encouraged to develop in as many units as possible in UK. Next one, please. So what do we need? We need a good team and good team working, and of course, continuous training and training new members of the team. Nevertheless, it goes to say that we do need instruments that's appropriate for this, which includes the HD stack and of course the robot in robotic surgery. We'll try and show a little video of the minimally invasive in the next slide. Next one, please. This is the standard instrument, as you could see on the left-hand panel, where the instruments are appropriately sized for open sternotomy. Of course, on the right side, you could see the long shafted instruments, which are essential for minimally invasive surgery. Next one, please. And as I mentioned, the high definition stack is instrumental in supporting the surgeon and the team for performing and getting a successful outcome. Now I think we shall run the video in the next slide. And if you click that place, I hope it will run. And if you click on the slide, please, that should run the video.
Sorry, it will not. The video has to be played as a separate file, so the video here will be able to play.
All right. Okay. Sorry about that. Specifically, catch that then. Maybe we could go on to the next slide then, please. And again, the minimally invasive surgery can be carried out in complex patients. Example in this lady where there's no sternotomy scar, and you can see the scar which is tucked underneath the inframammary fold, and so the recovery of the patient is much quicker and improved cosmesis, and as you could see, it could be hardly visible. On the next slide, please. So what about robotic surgery? Of course, it's a evolving field, and it's not many institution has got the facility, and it needs a lot of vision from the hospital managers, and you have to buy in. And of course, we do have in Liverpool at the moment, and I've been just joined into the hospital here. Next slide, please. And what does robotic is advantages over anything else? Yes, it does provide 3D high definition, tumor filtration, and 10-time magnification, so the surgeon can really zoom in and see exactly what he can do, or she can do. Of course, we don't have the tactile feedback, but that's as a learning curve in everyone else we know. And next slide, please. And I'm sorry, the slides are not going to run, I guess. This is just to show how the binocular vision of the surgeon looking into the console during robot, which gives the high definition picture, so that we can operate obviously quite nicely. Excuse me, next slide, please. I'm really sorry about this. Images are not running. Just to show how closely the surgeon can view the mitral valve repair during robotic surgery. And here is to see the P2 is prolapsing with excess tissue, and the P2 was resected and was reconstructed during this procedure, and they did have an excellent outcome. And next slide, please. And again, apologize for this video not running. This is a redo operation where a patient had a first time mitral and aortic valve replacement. Subsequently, he had endocarditis and ended up having a paravalvular leaks. He did have 2 or 3 amplats device to close the paravalvular leak, which failed unfortunately. So he was done robotically through right chest, where the amplats device were removed and the mitral valve prosthesis was removed as well and replaced with a new one, and the patient went home successfully. On the next slide, please. So in endoscopic robotics, what is the thing you're looking is the value of the surgical approach is equates to the quality and outcome over cost and the invasiveness. And next one, please. And you can see the scar in robotic surgery. It's even less than mini thoracotomy, albeit there are a couple of scars in addition for the port access. As you can see, the outcome is really good. Next one, please. As I mentioned before, the learning curve is important in any surgical specialty, but it's even more important in minimally invasive and robotic surgery because it's long and steep. It's difficult to say how much we need for every individual. It's based on individual's experience and their training. As soon as we think it's acceptable standard in any procedures as we expect, the curve flattens down, but there is a dip, as you could see, is the secondary learning curve where you end up taking more complex cases and you will see a dip in your outcome. But if it persists, then we can achieve a good results with that. Next slide, please. This is a slide showing intraclude device, which is a balloon inflation device, goes from the groin. And the idea is to place this balloon in the ascending aorta, where it can occlude the aorta internally, which can facilitate to arrest the heart and by pledging the heart in the aortic root. This is very important in particularly in redo situations, which can be obviously done in the first time operations too. This has actually revolutionized the redo cardiac surgery and as a good armamentarium to have for minimally invasive and robotic surgery. Next slide, please. Since we have time, we can touch upon, as I mentioned, the percutaneous techniques, which are evolving at the moment. Like TAVI, these percutaneous techniques are surfacing, and they are carried out quite a bit in America and Europe. And the one center, I think, is the Brompton, doing it as well. We can divide it into 4 domains, i.e. the ones that deal with the leaflets, like leaflet repair with MitraClip, can be done through transjugular or transfemoral route. Neocords and harpoons are done through transapical route, and I hope that will reach in multi-centers soon. There are annuloplasty devices like cardioband, Carillon, Millipede, and so on and so forth. There's been done and shown successful results too. There are LV remodeling devices like Accucinch and Ventouch, and again percutaneous transmitral valve implantation, either transfemorally or transapically. The one which I would like to point out is the Tendyne. There are other things like Tiara and CardioQ and Intrepid as well. Next slide, please. Sorry for this busy slide, just trying to compress all of them. we can divide these annuloplasty devices into direct and indirect. The indirect one is the, as you could see, the left-hand side is the Carilian mitral contour system, which can be placed in the coronary sinus, try to reduce the posterior mitral valve annulus and bring the two leaflets to co-op together. And there are direct annuloplasty devices, as I mentioned before, cardioband, which can be done through transfemoral after passing through the transeptal route, mitral line, millipede, and others, as I mentioned before too. And the next slide, please. Transcatheter mitral valve implantation or replacement, however we call it. There are quite a few on the market. And as mentioned, Tiara, CardioQ, Tendyne, Interpret, Navigate, Highlight, and Caisson devices. The one that has been, I think, approved is the Tendyne one. And I think a couple of cases have been performed in Brampton recently too. Next slide, please. Let's think about the future. Our population is getting older, and we are dealing with patients who have comorbidities too. Let's say John or Smith, whoever he is, probably 82-year-old, comes with a history of shortness of breath and exertion. Let's say he had an echocardiogram done which shows severe mitral regurgitation. He's got a good LV. He's got no coronary artery disease. He's got comorbidities. He's diabetic type 2, and he's got chronic kidney disease. He's got mild COPD, had a history of TIS in the past, and he's got prostatism, arthritis. And he is a main carer for his wife, who has got Alzheimer's. And let's stop for a moment and think, what do we offer? Okay, of course, standard sternotomy. Next slide, please. Is the standard which you can get good results, but given his age and comorbidities, he may end up spending a lot of the time in ITU and in hospital, and it costs money for the hospital, for the patient as such, and it costs the time the patient wife has been looked after, and so on and so forth. Next slide, please. Let's say if you can do the same surgery for John through either mini thoracotomy or robotic surgery, where we can aim to send him home early, where his recovery will be much faster, and he can go back, start looking after his wife as well. And next slide, please. If we just start looking at the things in a different angle, we can achieve the same results, or even better. We just got to look at it differently in this old peculiar time. Thank you very much for listening. And I'm sorry the slides are not working. And I'm happy to take any questions.
Shan, the Q&A will be at the end. Okay.
Okay.
Bhuvana, if you can please. So what we're going to do now is that we're going to run a poll, and which is, the poll is going to take about 20 to 30 seconds. We ask the audience to please scroll down a little bit on your screen so you can see the poll underneath the screen that you see the slides right now. So if you scroll down, you will see the polls now for you to rate the session, please. And there are 5 stars. Thank you very much, Shan. And if you would be so kind as to press to close your camera and to press on the red button on the screen so you can leave the stage. And Bhuvana, if you turn your camera on for me to for you to introduce the next speaker, please. So Shan, if you press the red button that you have on the screen that looks like you're up a phone.
I'll try and do that. I'm just trying it now. Do beg a pardon. The mouse is playing.
Thank you.
John, can you able to see me?
Yes, we're able to see you, and you can introduce the next speaker, Bhuvana.
Now?
Yes, you can do that right now.
Okay. Thank you so much, everyone. Thank you for listening to our Mr. Sean Shanmugam. I'm really sorry he was not well for past a few weeks. He couldn't able to upload MP4 files, but he did kindly come today to do online presentation, but the videos didn't work. I'm really sorry for that. Our next speaker is Mr. Chris Decker. He's going to talk about the atrial ablation surgery versus medical management. Thank you so much for listening. And I will just introduce Chris today. So Chris works as a product manager for Europe, Middle East, and Africa. His background is that he was an NHS nurse for 25 years, working in ICU, arrhythmia, and clinical research areas. His day-to-day job at AtriCure now to promote the awareness and understanding in the surgical community of the devastation and the impact of atrial fibrillation can have on lives on patients, and also the treatment options can improve the symptomatically and reduce risk. Thank you, Chris.
Hello, and thank you very much for taking the time to watch my presentation. My name is Chris Theaker. I work for a company called AtriCure, and we make products for surgical ablation. I have spoken at this forum before, and it's great to see that it's back on this year, although virtually. I'd like to talk to you about the treatment of atrial fibrillation, which is often put aside in the surgical setting when patients are coming in for either their valvular surgery or to have their CABG done, or indeed both. And the patient has atrial fibrillation. Historically, the valve and the CABG have often taken precedence. In fact, we even refer to patients, or they're having a CABG done, or they're having their mitral done. The fact that they've got atrial fibrillation seems to get missed. As I spoke at this forum before, I pointed out the inherent mortality and morbidity associated with the acquisition of atrial fibrillation, and it leads to early death and very poor outcomes with patients. But the problem is, treating the AF during concomitant cases adds pump time, and people get very worried about that. And it's a bit counterintuitive that you stayed on the pump for a little bit longer and treated the AF, that you would get a better outcome. But I'd like to show you some data now that has been collated from lots of studies that show the benefits of patients having the AF treated concomitantly versus those patients who didn't have their AF treated, and over a surprising time frame. So if I may be so bold, I shall just share this first presentation with you. And really, it's this slide. If we look here, we see a study, 1-year mortality associated with ablation for atrial fibrillation during coronary artery bypass grafting. The study in the middle looks at outcomes of those patients who have had atrial fibrillation treated concomitantly, and looks at 5-year outcomes. And this study looked at 10-year outcomes associated. So what do we see? We see early, mid, and late outcome data for the benefits of being treated for atrial fibrillation. Now, the early data, if we turn our attention to this paper, first of all, with some nearly 4,000 patients, why do we need to know the early data? Well, we need to know the early data to make sure it's not a risky procedure. If it was, as is often thought, you would see that in the 1-year early data. You would see a rise in death or morbidity within 1 year. But that's not what we see. We see quite the opposite with that. We see that actually those patients who had AF treated, and it was all sorts of AF, whether it was persistent or paroxysmal, and it didn't really matter what procedure was done, although of course the full Cox-Maze is the gold standard. But there was a 42% higher survival rate in those patients who had their AF treated after 1 year. That's fairly significant. This is epidemiological data that we're looking at here, where people have gone back and looked in the registry on how their patients, in order to check how their centers were doing with these patients. Are they doing the right thing? They were questioning, are they doing the right thing? So they looked at their data, they looked at their epidemiological studies to glean this data and put it out to show that treating AF does have significant benefit advantages. Now, if we look at the midpoint paper here, we see there's a multi-center analysis, several different centers. So it's all looking at care in different hospitals. And also what they're starting to do in these studies now in the mid and late studies, they're starting to match patients risk for risk. So if you had diabetes, you'd be matched with a patient who had diabetes but did not have concomitant surgical ablation. So you can balance out the risk amongst the group. Propensity matching is the technical name with it as well. But what do we see here? Do we again see poor survival, that extra time on the pump associated with that? No, we don't. We see quite the opposite of that. Again, we see that after 5 years, those patients who underwent concomitant surgical ablation actually had a 31% survival, better survival out to 5 years, starting to show that there is a long-term benefit associated with having surgical ablation, having a maze procedure, and it also seems to reduce the mortality. But what about long-term? What about long-term data? We really need to know if it's worth it 8, 9, 10 years out. Well, this paper confirms that in a not small population, in a large population, 10,000 patients were analyzed. And they found that actually that the maze procedure was improved survival right out to 10 years. And if we flip back to the 5 years, we're seeing big numbers here, 20,000, 10,000. So a huge number of patients have been analyzed to come to the conclusion that actually this procedure, an ablation, has benefit associated with it. And actually, if we look at this through a different set of eyes, what we're seeing here is real-world data. What actually is going on in clinical practice? This information is not within the artificial confines of a study. This is what's happening in centers that ablate. And so we can take that if this is happening in real world, we're starting to see these real world benefits with it as well. And that shows that the patient population is very mixed. The patient population is very diverse. And so there seems to be this sort of protective benefit, one might call it, associated with treating AF surgically. But also like to go on and just reiterate those points because they are very important. There's been notable studies that have shown just the restoration of the patient to sinus rhythm has shown improvement of life in life and reduced mortality. So getting that patient back into sinus is vital. You know, it's not always achievable, but even if you're doing something, the data seems to suggest that you are having an impact. That impact could be not only that you're trying to get them back into sinus rhythm, but also that the amount of AF they in is less, the patient is in is less. The reduction in AF burden is not in it so much. Maybe they were in it 100% of the time, but now they're only in it 10% of the time. That reduction in AF burden is quite interesting because with that goes reduction in symptoms as well. If you had 100% of the time you had symptoms associated with a disease state, shortness of breath, dizziness, tiredness, lethargy, and suddenly said, well, actually, I can reduce that by 90%. I think you would think this would be a worthwhile therapy to go for. However, we just got to remember as well that according to the American societies, this is a very profound treatment. It's a class 1 recommendation from the American societies, showing that there is definite evidence to show that this procedure has benefit. Now, you may say, well, those papers I showed earlier, they do not show randomized controlled trials. Well, there is a randomized controlled trial already published on that. So there's increasing data across the board, both in the epidemiological and the randomized controlled trial, that the reduction in symptomology of these patients is notable. Now, I just want to give you a little time tree here. If we imagine our patient here, this is their journey. They're going through the years right from 1 year, 2 year, 3 year, 5 years, all the way up to 10, 15 years. And these are the benefits that they will get as they move through the years and the publications that confirm them. So although I showed 3 papers earlier on, I wanted to show those 3 particularly because I wanted to show early outcome data, midpoint data, and late outcome data with these patients as well. But interwoven within that is a cacophony of other studies which confirm benefit at different time points. Those 3 papers were chosen because they have big numbers and are really showing the benefit of atrial fibrillation treatment. So I think you'll agree with me that there is a wealth of evidence, in fact, 14 articles that have analysed over 48,000 patients showing benefit of treating AF surgically. Now, if you want to know more, please feel free to reach out to me or visit our website, www.actagainstafib.com. And hopefully we can start to work and see the benefits of treating AF and also understand the harm that this terrible condition that is so often undertreated and so often under-recognized can start to be treated and the patients getting the care they truly deserve. So thank you very much for your time. I hope you enjoy the rest of the conference, and I look forward to meeting you in person and having some great discussions about treating patients who have AF concomitantly, and we can hopefully work together and start to make a real change to these patients' lives. Thank you very much. Bye-bye.
Good morning, everybody.
Orthopedic surgery, 5 years in cardiothoracic surgery, and he started the endoscopic vein harvesting and endoscopic radial harvesting at Royal Brompton in 2009. And now he works for the Getting since 2014. But today he is going to talk about as an expert global clinical trainer for the endoscopic vessel harvesting. Thank you, Ganesh, for speaking. Thank you.
I would like to thank the Society for inviting me to present the endoscopic vein harvesting step by step. My name is Ganesh. I am a clinical trainer supporting the global training for EVH and ERAH procedure. So let's have a look at what we will cover today. So first of all, we'll review all the coronary artery bypass graft sources, and we looked at the pre-procedure preparation, some of the key features of EVH equipment, and intraoperatively, how do we perform the procedure. And at the end of this presentation, I will answer your question. So when referring to coronary artery bypass graft surgery, we all know that the gold standard is using the Lima to LAD, and there's no doubt about this. Any further grafts are needed, we will take a length of vein from the legs, or the radial artery from the arms. A few ways to achieve these are the open techniques and the endoscopic techniques here. Look at the right side. The patient has both radial, open radial, and endoscopic radial. To start the EVH procedure in a cardiac unit, you will need the following equipment. First, the camera stack. The camera stack, you'll find this in most cardiothoracic units. The only thing which will be missing is the CO2 insufflator. And you need a CO2 insufflator for the vein harvesting. That's going to help you to clear the vein and maintain a consistent tunnel while you're working on the vein. We will also need the basic vein surgical instrument, an extended length scope, appropriate cables for the power supply generator, and then the harvesting kit, which is a disposable kit. The next step is to know where to position this camera stack in the OR. It is always important to get the OR staff involved in order to plan where the equipment will be placed. The most optimal places is directly opposite to the harvester. The harvester will be here, the monitor will be directly opposite to the harvester to work. But more frequently, this is what you see. You see the harvester here and the monitor is at the foot of the table. So the harvester can work on either leg. The rest of the equipment will be the 7mm 0 degree extended length scope. It is 49 centimeters in length and got a threaded distal end. It can be mounted on any light leads with appropriate adapter and is universally mounted to any camera head. The power supply, generator, and the cables. This will be connected to the harvesting tools in order to mobilize the branches and the tissue during transection. Then you have a harvesting kit, which is disposable. It's disposable. And in the harvesting kit, you have a conical tip, which is also called a dissection tip, which is mounted on the endoscope. You have the harvesting cannula, the harvesting tools, the port to keep CO2 into this leg while you're working on the vein. Intraoperatively, prior to proceed with EVH, it is important to consider the following. First of all, the patient characteristic and the effect on the harvesting. Secondly, will be the method to locate the vein. And thirdly, how to position the patient. Let's have a look at the patient characteristic. The ideal patient will be an average built male and one length of vein to start EVH. The challenging patient will be obese patient, very thin patient where the vein is very superficial, and also when you need multiple lengths of vein. The method to locate the vein can differ in different hospitals. You can have the patient you can send the patient for a vein mapping. Sometimes the vein mapping can be costly, even though it's done in-house. You can also use the old method like milking the vein, which is also called vein purging, or using the anatomical landmark. But I found that the most efficient approach is an intraoperative ultrasound. This will give you the ability to assess the quality of the vein. Patient positioning is the best way to position the patient is frogging the legs. Frogging the legs means you flex the knee and externally rotate the legs, but keeping something underneath the knee to keep it in this position. So by keeping the legs into this position, you allowed yourself to have full control over instrumentation. For incision location, we can have a few options. First, it can be at the knee, above the knee, or below the knee. But then again, if you need two lengths of vein, of course, you will need to think where you're going to make your incision. And the appropriate place to make your incision is below the knee, because then you can easily get two lengths of vein. Where not to place the incision is at the groin or at the ankle. So having the incision at the groin can actually obstruct your instrumentation. The abdomen is going to be in the way, and you won't be able to work down the legs. The same thing with the ankle. If you make an incision near the ankle, the medial malleolus is going to be in the way, and you won't have the full capacity of using your instrumentation. When it comes to the incision, there's a few types of incision we can make. We can have either a transverse incision or an oblique incision. These incisions are made mainly if we don't have an ultrasound. But if you have an ultrasound, it's easier to have a longitudinal incision, because you're going to make the mark on top of, you're going to ultrasound the legs, make the mark on top of the vein, and it's easier to find the vein this way, and the incision will be better having a longitudinal incision. To find the vein, we use a standard surgical approach. We start with a 2 to 3 centimeter skin incision. We'll find the vein on direct vision and open the disposable kit. Then we have to create a hood. What is a hood? The hood is a space between the vein and the skin. So we're gonna clear this subcutaneous tissue here. And it needs to be big enough so that your blunt tip trocar port can easily slide in. Once you have a port in, then you will start CO2. You need to utilize CO2 to proceed with the vein harvesting. And it is a harvester's responsibility to check ventilator setting prior to utilizing CO2. So you need to make sure that as a harvester, you need to make sure that you have the flow setting at 3 to 5 liters per minute and with a pressure of 10 to 12 millimeters of mercury. So you should not go above this pressure. It's quite safe to go below it, but never change it and go above it. The other thing that you're going to start thinking is informing the anesthetist, just in case there are any changes to the patient parameter while you are using CO2, and the anesthetist will inform you. To work on the vein, we use a systematic approach. We start with an anterior dissection, then move to the posterior dissection, and finally the lateral dissection, the side dissection, where we're going to start freeing the vein. So let's have a look how we do this anterior dissection. The anterior dissection is achieved by keeping the vein down at 6 o'clock. If you look at this here, look like a clock, keep it at 6 o'clock and move forward, in and out, let the CO2 go in and allow you to clear this vein. So we have the posterior dissection. Again, the posterior dissection is achieved by keeping the vein at a 12 o'clock, keeping this as a clock face here. So you keep the vein at 12 o'clock and the same movement, in and out, just to keep the CO2 clearing some of the tissues and maintaining this tunnel. Once anterior and posterior is done, then we'll move to the lateral dissection. The lateral dissection is where we're going to work more likely on the branches and all the tissues which is still stuck on the side wall. So if you see a branches like this, you're going to make sure that you're going to work on it, get yourself a good length, so that later when you come back to do the transection, you will get a good length of vein, to good length on the branches to work. So once vein is free, the next step is the branch closurization and transection. So it's important to start from the distal end of the tunnel and work yourself backward to the proximal of the tunnel. And when you advance to the proximal distal end of the tunnel, it's important to keep the tunnel clear. If there's any small branches or tissues still attached here, it's better to clean it before you go further up and then work your way back. And it's always advisable to keep the searing in front of your branch before you cut it. That will protect the vein and you're cutting your tributaries. Last step will be running the vein. We run the vein to ensure that all the tissues and the branches have been disconnected. So again, we will work from distal end to proximal end. And if we're working on the thigh, we will start from the groin and work backward to the knee. The same thing down the lower legs. If you're working in the lower legs, you're going to start from the ankle and work your way backward. And making sure that all these tissues are clear. Then we're going to have to disconnect the distal end. So to disconnect the distal end, we make a small stab incision, about 2 to 3 millimeter. Use a curved mosquito to go into this tunnel, and then retrieve the vein, externalize the vein, and under direct vision, we're going to transect it. Once the vein is transected, before dropping the stump in, it is advisable to transfix it instead of having a clips on it or tie on it. We then remove the vessel in a retrograde fashion near the port side. And once the vein is out, we will prepare it according to the surgeon preferences or hospital protocol. At this point, I always get a question asking me, do we really need to tie these branches or clip these branches? Yes, we do have to. Here's the thing, that we're taking this vein from the legs, which have got a low flow in the legs. And then we're going to put this vein on the heart. We're going to transplant this vein on the heart. So we're going to have a high flow running into this vein. So these small branches that we have sealed, it will open. So it will be advisable to tie the branches and clip the branches. When it comes to dressing and closure, there's no special recommendation. What I normally advise my trainee is to do what they normally do when they open the legs. They use a stitch to close the wound, and use some subcutaneous stitch and close the subcuticular layer. But then we also go according to the surgeon preferences and the hospital protocol. And I will also advise that you put a tight bandage on it, because understand that we have created a tunnel in these legs. And we don't want to leave the tunnel open. So by putting a tight bandage on, we're compressing the tunnel. So if there's any oozing in the legs, so that while compressing while putting some pressure on the legs, that will stop the ooze, stop the bleeding. And we have come to the end of the presentation, so I'll be more than happy to take any question now. Thank you.
We have one question, Bhuvana, from the audience that says, "What is the role of ECMO in trauma?" So I will leave you for the Q&A.
So, Vipin, would you like to answer that, please?
Hi, can you hear me? Hi, thanks. So, ECMO in trauma, again, the risk with ECMO is of massive bleeding. And when somebody has polytrauma, they have broken bones and broken ribs, and there is lots of injuries. At that time, I think ECMO CPR is the only option, which if somebody presents in a cardiac arrest and it was a witnessed cardiac arrest, only then you would consider ECMO. But the outcomes are likely to be complicated by severe bleeding, and therefore it's not really a very good option in terms of severe trauma. If they present later on, if somebody has a long bone fracture and they develop a fat embolism or a massive PE, then that is a different scenario, slightly a few days after the polytrauma, when the bleeding has stopped and they have suffered a catastrophe which can be reversed, then ECMO may have some role.
Thank you, Vipin. It was asked by Mr. Raghav Hassan from MRI. So we are waiting for the questions to come. Sean, it was a very interesting videos. It will be nice for you to upload them as a video so everybody can watch, because that's what I'm getting all the text. It was amazing.
Will do.
Please, if you can do
Sorry
that.
about that. It just wasn't appropriately done. But yes, of course I can do that.
And we have another question for you, not for Sean. How do you manage the open chest situation? And that was the question.
Can they explain a bit more?
So they didn't give anything. And the question is about how do you manage the open chest situation? Maybe it is about mitral valve surgery. If you need to open up, how do you open?
Oh, I see. Bleeding? Right. Okay. Yes, of course. I mean, if it depends what is bleeding, and it's difficult to see unless we have a good view. Most often, the bleeding points are only two places, which is the ascending aorta, where the cardioplegia cannula is inserted, and number two is the atriotomy site. So it's only 2 points which can most often bleed, and we secure that before we close the patient. And there are other places which can bleed at the port sites, which are sometimes painful when the intercostal arteries are damaged or get knocked off. But it can be addressed again through the port site. And if it's a massive bleed, the best way is to do a sternotomy and secure the patient first. So patients, obviously, life is important when it comes to it. And if it's in a severe bleed, sternotomy, if not, access through the same port. And it can be dealt with the same port.
Thank you, Sean. Until somebody is asking another questions, can I just ask you something? So any tips, tricks, or techniques do you, say to the new consultants who wants to get involved in the mini mitrals?
Absolutely. I mean, I would encourage people who are surgeons can do minimally invasive as well. Training. That's what I would say. And have a buddy with yourself. Have a proctor. Go for a fellowship somewhere 6 months to 1 year if possible, and train yourself. What I did is my experience before I started getting into mini mitral program. I had a feeling, a model where I can work on in my office every day. I was playing with it for 6 months. During that time, I used the long shafted instruments in the open chest patients so that I can get used to the instruments and the staff, medical staff, nursing staff as well. Then I went on to the fellowship for 6 months in Germany, which was then the instruments by the time became a second nature for me, and working on the small hole became a second nature as well. So combining that with the fellowship was very helpful. Then we had a dry run in the hospital, make sure every team members know what they're doing. So we had dummy runs like 3 times or 4 times. And then we had proctors come in and then we went on solo. So it's a long path, but it can be done.
Okay, thank you so much, Sean. I have another question, but I will ask. We have a question from Vipin for Ganesh. Ganesh, Vipin said that he is a pro in EVH. The recent study says the minimally invasive harvest has low patency rate. Any comments? Any further studies coming up?
Can you hear me? Yeah. All right. So the thing that so far, the last study that came out was a regroup trial in 2018. So apart from this, there's nothing that came out. But again, the regroup trial is not about patency; it's about mortality rate and the difference between MACE, between the open techniques and the endoscopic techniques. So yeah, any new study hasn't come out yet about the patency. But thinking about it, the most important thing we need to remember, in America, we've been using EVH for the past over 20 years now. And so they are happy with EVH, and they haven't had any issue, with mortality rate. They haven't seen any changes. So that's why we keep on proceeding with EVH. And I'm pretty sure even in the UK, this is what's happening right now. And most of the guidelines that we are following right now, the EAC guideline, and NICE guideline, and even the SMIC guideline, they are pro EVH. Mm-hmm.
Yeah, just to add Ganesh point that there was a paper published 2 months ago by Marco Zanatia, the part of the regroup trial, and they did a midterm evaluation of 4.5 years and showed clearly that the MACE is a rare intervention, and also the mortality is similar or better in EVH compared to the open vein harvesting. And that is published in JAMA Open. You can access it, Vipin. And there is another study for 10-year outcome of UK trials with 49,000 patients, which is submitted, and that shows the endoscopic vein harvesting is, equal as well. And there is a question. Thank you, Ganesh. There is a question for you, Vipin. How do you assess satisfactory RV function when transitioning from BIVAD to LVAD configuration? Please.
Hi. So that's a very valid question. I think it is a very, very difficult assessment. Once you're already on BIVAD, the RV is already emptied out by RVAD circuit. Therefore, the only way to assess the RV function is to gradually, under supervised condition, put a TOE probe down and then gradually turn down the RVAD flow and then make a subjective assessment that how the RV responds. If the RV starts to dilate, the atrial septum and the ventricular septum start to shift towards the left side, that means that RV is fully overloaded. So if you cannot reduce the flow fully, so therefore you cannot turn off the RVAD fully. So you can gradually come down to 2 liters of flow, and then for a few seconds you can even reduce to maybe 1 liter, but then you're risking clotting the circuit. So therefore you want to gradually reduce the flow with TOE guidance, look at the heart and the septum and the volume overload status, and then make a subjective assessment.
Okay, and there is a second question for you. Usually mechanical support patients used to be thought to have a record 2 nurses, but this has been reduced to 1:1. So is this a common practice in your area, or in your opinion, is it good or bad? From Tara.
Hi, thank you very much. So again, I think it is mainly based on the experience and the expertise available in the center and the workload. So once we have had a lot of COVID patients, the staff were really stretched, and at places we have had the bay coordinator looking after, and then the patients who are on the BIVAD or the ECMO have been managed with one nurse. So in our unit, it is usually one nurse, and they are able to run the ECMO, the filter, and everything else. But they have lots of circulating support available. So there is an ECMO coordinator, there is a nurse coordinator who is helping sort of 6 bay patients. So in a new unit, I would say it is definitely 2 nurses or even 3 nurses required initially, one to run the filter, one to run the ECMO, one to run the general nursing care. But if you are in a very experienced unit, which does it routinely, and resources are stretched and it's a COVID pandemic, then it is feasible to have a perfusionist helping you out with the ECMO, the main ECMO coordinator helping you out if there are any issues. Usually, if there is no bleeding, they are all stable, so you can manage.
Okay, thank you so much, Vipin. Sean, you got one question. What quadriplegia has been currently used for the minimally invasive
That's a good
mitral
question.
now?
Thank you. We use custodial quadriplegia, and that gives about 60 minutes to 90 minutes of cross-clamp time without re-intervention or re-pledging, in fact. Anything beyond that, the second dose will be given, but generally we finish up before 90 minutes. Excuse me. So yes, custodial quadriplegia is ideal for this, really.
Thank you so much. We have not got any question yet. Just I got one question.
Yeah, sorry. I was wondering whether I can ask a question, but I'll go after you, Bono.
Yeah, just I'm asking, what is the learning curve period for people who is starting the mini mitrals? Do you have any?
That's a very good question. Yes, indeed. I mean, I can only speak from my experience. As I mentioned, I was using the instruments for 6 months before I went to Germany, and I spent 6 months in Germany, day in and out operating. And after that, I had proctors come in and took about 6 months to establish not necessarily myself, we got to train the team. So we're looking at about a year and a half to 2 years by the time you plan, and then, excuse me, you can start the practice safely. And if you have an experienced surgeon next to you, you can cut short the time a bit even shorter. If you don't have anyone in your unit, like myself, it did take 2 years to do that. And as I said, it's doable. You got to have determination and have the appropriate support in every angle you can have, and it's definitely manageable. My question to Ganesh: endoscopic radial harvesting. I wonder what's the length of the radial that you would be.
So that will, if you're operating on a big long patient, you will have a big heart. The arms, you will see it's going to be long enough for one length to use on the heart. So I don't think my own experience having doing so many radio, I don't think there's any limitation to take the length of a radio, because sometimes the important thing, if a surgeon has measured the length for you, that make life a bit easier for you. You don't need to take the whole radio. But again, when you take the radio, you have to be very careful how far you're going to go.
Yes.
You don't want to go to down end of a cubital fossa, and then you end up like seeing the ulnar artery and damaging the ulnar, and then suddenly you won't be able to proceed forward to take this radio.
Sure.
So again, we have to give and take, and the important thing, as I said, if a surgeon measure it for you, you know exactly how long you're going to get the radio, it will be easier.
Sure. Now, the recent question asked is doing full arterial revascularization. I do a Y-graft Lima radial, and we kind of we haven't written it up. It's on the process about getting 19 centimeter on average. Let's say 18 or 19, gives that perfect length to go all the way around to PDA. I guess with endoscopic, proximally you can reach up to the ulnar or interosseous branch, but distally, how far would you be able to go? That was the question I was directing.
Yes, distally you can go. The thing that we use a crease of a risk. Okay, sometimes we go below the crease. The issue you're going to have, the healing process will take longer.
Correct.
You can do it. There's no restriction to take it out. But the thing that, remember, you got this crease here, so that's why you need to be careful. But the minute you go below this crease, you have more chance of the healing process will take longer, and that might create a bit of issue here.
Thank you.
And you have a median nerve as well, isn't it? That's what you have to be an interosseous branch at the top, so you have to be really careful as well. Thank you so much, guys. We have to finish it now in 1 minute. And thank you so much for coming today. And all gentlemen, Vipin, Sean and Ganesh, thank you so much for coming. And everyone, thank you so much for listening. It is very hard for us that we are just seeing the laptop and speaking, but we had excellent talks and excellent question and answer. Once again, thank you so much. Enjoy the day.
Thank you, guys.
Bye.
Thank you, everyone.
Thank you, everyone.
Bye-bye.
Thank you.
Bye.
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 Great work, everybody. Excellent.
Thank
Thank
you.
you.
Bye.
Benjamin, Ben.
Yes.
Oh, thank you. You are very early.
Well, I was worried that I was worried I was going to have problems, so I thought I'd better just try and get in early.
That's good. We just finished our first session,
Mhm.
and today Joel is not going to come.
Yep.
You and Marcus is going to. So, but one of you only needs to. Marcus is there.
Marcus
So
is
what
here.
is the? Good morning, sir.
Good
So what
morning.
is the problem we are having is only one of you can chair the session. One of you can introduce and everything. That's what it happened with the morning. Even though we put 3 chairs, but we couldn't able to do for
Okay.
the proper flow consistency. So if one of you can introduce all the speakers, and you will be on the stage, but you will be at the back.
So I'm happy to let Marcus chair. As
Yeah.
you might have noticed, I'm in an environment where I could